An assortment of special tests have been developed to examine individual structures of the shoulder. It is important to recognize that many variations exist for each test. Regardless of the maneuver utilized, a standard physical exam of the shoulder should include provocation and analysis of, at a minimum, the following structures: cervical nerve roots, rotator cuff tendons, glenoid labrum, biceps tendon, and acromioclavicular joint. Here, we provide examples of commonly employed maneuvers to evaluate each of these structures. However, the practitioner should feel permitted to supplement alternative tests with which he or she is most comfortable. We typically begin our assessment with Sperling's test, which is designed to identify cervical nerve root impingement. Thus, a positive finding will often prompt greater subsequent focus on the neck rather than the shoulder as a primary source for the patient's symptoms. To perform the test, the patient is positioned either seated or standing with the examiner behind. The neck is placed in lateral rotation and extension. The examiner applies a downward axial load to the cervical spine. Reproduction of radicular pain suggests cervical nerve root impingement. We often move next to maneuvers designated to evaluate the rotator cuff complex, as this represents the most common site of shoulder pathology presenting to physicians. To begin, Hawkins-Kennedy test is useful to assess for subacromial impingement, which most frequently affects the supraspinatus tendon. To perform the test, the examiner stands on the side of the affected shoulder. Position the patient's arm in about 90 degrees of shoulder flexion with the elbow comfortably flexed, between 60 to 90 degrees. Stabilize the scapula with one hand on top of the shoulder and apply forced internal rotation with the other hand. It is often useful to perform this test with the arm in varying degrees of abduction and adduction. Reproducible pain over the anterior shoulder with forced internal rotation indicates impingement. It is important to recognize that subacromial impingement may be primary or secondary in nature. Primary impingement refers to true structural compression related to anatomic anomalies of the anterior acromion, the coracoid, or the coracoacromial or acromioclavicular ligaments. This may arise, for example, in cases of a hooked acromion, osteophyte formation, or deformity from fractures. However, more commonly, impingement arises secondarily, due to altered scapulohumeral mechanics in the setting of glenohumeral instability or muscle imbalance caused by underlying pathology. Thus, the finding of subacromial impingement must prompt a complete investigation to exclude principal causes. To continue the examination of the rotator cuff complex, the empty can test is designed to more specifically assess the structural integrity and functionality of the supraspinatus tendon. The patient is asked to position the arms with the shoulders moderately abducted and flexed to 30 degrees. Then, the patient should point his or her thumbs down, as if emptying a can. The examiner applies a downward resistance as the patient attempts to lift or flex the shoulder. Pain and/or weakness may indicate abnormalities of the supraspinatus tendon. True weakness may suggest a significant or full-thickness tear of the tendon and should prompt the practitioner to consider more immediate referral, particularly in the setting of a history of trauma or acute event. However, pain can often interfere with the strength evaluation. Given the importance of differentiating true weakness from pain-limited weakness in subsequent management, the drop arm test may be a useful adjuvant. To perform this test, the patient's shoulder is abducted to 90 degrees. The examiner then instructs the patient to slowly lower the arm. The patient's inability to controllably lower his or her arm often favors a diagnosis of true weakness and a massive tear of the supraspinatus tendon. The remaining muscles of the rotator cuff complex, the infraspinatus, teres minor, and subscapularis, may be initially screened with resisted external and internal rotation of the shoulder. The patient is positioned with the arms at the side and elbows flexed to 90 degrees. The examiner applies resistance as the patient attempts to externally and then internally rotate the shoulder. Reproducible pain or weakness with resisted external rotation may indicate infraspinatus and/or teres minor pathology, while pain or weakness with resisted internal rotation may indicate injury to the subscapularis tendon. As previously mentioned, pain may hinder the examiner's ability to identify weakness with resisted testing. The drop sign, not to be confused with the drop arm test, may be useful to further assess the integrity of the infraspinatus tendon specifically. To perform the test, the examiner uses one hand to grasp the elbow while holding the wrist with the other hand and flexing the elbow and elevating the shoulder to 90 degrees. The shoulder should also be passively externally rotated to near end range. The examiner then releases the patient's wrist and instructs the patient to hold the arm in position. Failure to maintain the shoulder in external rotation represents a positive test and may suggest a significant tear of the supraspinatus, but even more specifically, the infraspinatus tendon. With regard to the subscapularis muscle and tendon, the belly press test may have additional utility to identify a significant tear. The patient is positioned with the elbow flexed to 90 degrees and the shoulder internally rotated such that the palm of the hand is resting on the stomach. The examiner should observe the position of the patient's elbow. A dropping of the elbow posteriorly into extension is a positive test and indicates a subscapularis tear. After examining the rotator cuff complex, a basic shoulder exam should also include special tests targeting the labrum, biceps tendon, and acromioclavicular joint. An effective test to assess the glenoid labrum is O'Brien's test. To begin, the patient's shoulder is placed in 90 degrees of flexion and 10 degrees of adduction with the elbow extended and the forearm pronated and thumb down. The examiner applies a downward pressure as the patient attempts to lift or flex the shoulder against resistance. The maneuver is repeated with the forearm supinated and thumb up. A positive test is indicated by greater pain in the first position with the thumb down and may suggest pathology involving the glenoid labrum. Speed's test is designated to evaluate the biceps tendon. The examiner positions the arm with the elbow extended and forearm supinated with the palm up. A downward pressure is applied by the examiner as the patient attempts to lift or flex the shoulder against resistance. Pain localized to the bicipital groove indicates possible injury of the biceps tendon. Finally, the cross-arm test is executed by having the patient position his or her arm in adduction towards the other shoulder with the elbow flexed. This may be accomplished by simply asking the patient to reach for the opposite shoulder. The examiner imparts a gentle pressure at the elbow to increase shoulder adduction and stress to the acromioclavicular joint. Reproducible pain over the anterior shoulder indicates acromioclavicular joint pathology.